excited today to be speaking with really one of California's most important public servants in healthcare and social services. And of course, I'm speaking about Dr. Mark Ghaly, who was appointed by Governor Newsom as the Secretary of the California Health and Human Services Agency in early 2019, a fortuitous time, I guess, to join on our part. We'll hear about his views. Before joining Governor Newsom's team, he worked for 15 years in county health leadership roles in both San Francisco and Los Angeles. And for the past 2 years, he and the Cal HHS have been navigating the COVID-19 pandemic, prioritizing the integration of services and how we collaborate across state departments. As a primary care pediatrician, he has a unique perspective on the past several years and where we're headed next. So Dr. Ghaly, I know you didn't want a long introduction, so thank you for joining us today.
Dean Goldman, thank you for inviting me, and I'm looking forward to the conversation.
So let's start off with the mandate of your agency. It's tasked with expanding health coverage and access to all Californians. How have you worked to reach the most vulnerable residents in our state, especially during these times?
You know, I would say that mandate of creating Healthy California for All is one that we take so seriously at Health and Human Services that it's baked into our guiding principles, our strategic priorities, and the focus on vulnerable populations and equity-anchored lens really guides so much of the way we think about it. So how has it translated? I think if you look at the last 3 years in the budget, and as much as a budget is a representation of your values and priorities, I think it speaks for itself. There's been a number of investments, not just on coverage and access changes. For example, just in this current proposed budget, what we're finally reaching healthcare for all, that regardless of age or immigration status, in 2024, people are going to have coverage. I don't care if you're an 18-year-old with citizenship or a 45-year-old without. You're going to be able to access, if you're income eligible, the Medicaid program. So as we improve and make important investments in the improvement of Medicaid, CalAIM, the new Medicaid waiver agreement we have with the federal government to really invest in social drivers of health, looking at not just integrating health, behavioral health, dental health, physical health, but also moving way upstream to the social drivers of health. I think these are two meaningful ones. So coverage changes, getting more people covered, making that access meaningful, and the demanding that we don't just look through the healthcare lens, what we can do in the four walls of a clinic, but look at this broader, what many people in LA are familiar with, this whole person care approach, really baking that into the fabric of Medicaid. And then I think what we have noticed, and for those who don't know, Medicaid, 14.3 million Californians, nearly a third, if not more than a third of our state, half of the births in California, half of the kids in California covered in Medicaid. So when you talk about the future, it's really in Medicaid. And then if you look at towards more the end of life, 2/3 of long-term care stays are paid through for Medicaid. So the vital importance of Medicaid as a cornerstone, Medi-Cal is the cornerstone for healthcare in California, is real. And the fact that we get to invest in it, massage it, tweak it, change its direction to really be focused on people, I think gives us opportunities to focus on the most vulnerable. And I would like to think we've done that. And then we did it even more during COVID. Happy to go into that later as well.
Yeah, and actually I do want to follow up on that because, you know, you're a pediatrician, and actually I don't think people realize virtually every child in California has coverage. It has been an enormous success from a policy perspective. And, you know, this preceded your arrival at the state level, but it is a remarkable policy accomplishment that in this state, there are no children that are uninsured.
I mean, I think it's terrific, and I'm proud to be part of that story. But I will tell you the next frontier is let's make that coverage count. Where we are on data and transparency about outcomes is not where we need to be as a state. That is part of unfortunately, the next frontier of what we need to do. We need to make sure that basic things like developmental screens, adverse childhood experience screening, vaccinations, the basic bread and butter around prevention occur for every kid. Just because you have a Medi-Cal card or an insurance card doesn't mean that you have the tool. You have a tool, but you haven't unlocked that tool to better health. And we have a lot of work to do with the state. I think it's part of our serious agenda to make these improvements. So that's where the pediatrician experience says, we're doing okay, but we have a long way to go in this other area.
Yeah, no, and I want to come back to, how we do that. As an economist, we think about, we say, well, if something's available, it's free, then there are no barriers. But actually, we face enormous barriers to delivering these services. But I do want to come back to something you mentioned, which is behavioral health, because one thing the pandemic has really revealed is the state of mental health in this state and in this country, and perhaps globally as well. We're a university and we see it firsthand in our student population, but even in our staff and faculty as well. And we know there isn't always parity in the services and how we deliver those services. And, this may be, this is an ongoing challenge, I think, delivering both the behavioral and social care that's necessary to address the mental health crisis. So could you talk a little bit about how we do that here?
Yeah. So, I like to call the pandemic the great unmasker of inequities and the great accelerant for change. And I think in behavioral health, it really has been both. As a pediatrician, often in low-income safety net communities where I practice, the idea that there was a brewing, intense crisis, behavioral health, well before the pandemic is real. And it's just been unmasked, I think, become more personal for all of us. You talk about the university setting, it's amplified everywhere. There isn't a single person whose behavioral health or emotional wellness hasn't been impacted by this pandemic in some way. I hope temporarily, I hope not seriously, but we know that those are the outcomes for many. And so what we have now is an opportunity to take what have been a lot of innovations and great thinking and really put them into action, because there's the attention and critical will among all of us to focus on this. And what the pandemic also did, especially here in California, is give us some resources that we haven't otherwise had. So a year ago, my agency, with the governor's leadership, put together a $4.4 billion 5-year investment in children's behavioral health to transform the whole thing. We talked about Medicaid. There's a lot of kids in Medicaid, but there's a lot of kids outside of Medicaid. And this is an everyone in. Often for serious behavioral health conditions, Medi-Cal provides more comprehensive, timely services than private insurance. I'm sure many of the listeners have a story, have a friend whose behavioral health crisis went unattended too long because the insurance quagmire didn't get through fast enough. And so for kids in particular, we're going to say that's not okay in California. We're going to build the resources that leverage technology, set the expectations, train the workforce, work with our schools and community groups, support parents and guardians to say wherever a kid is on the spectrum, whether they're well and they just need a reminder and some support, or whether they're experiencing their first psychotic break. We want to be there for our young people, and we're going to put that together. So there's a multi-part plan 8 pieces in particular, everything from addressing stigma to investing in the brick and mortar infrastructure to make sure we have urgent care centers for kids and inpatient beds to kids. And frankly, most urgently, most importantly, and for me, this is one of the ways when you ask about vulnerable populations or equity concerns, we need to address the workforce. And this is going to be a and one in any part of today's conversation. Workforce, workforce, workforce. But in behavioral health in particular, we need a new type of workforce, not just more of what we know, but new types and classifications of workers. People who get into community and can be available on their phone, in a chat, at the door, wherever, to help support people through their emotional health journey. Because if we don't, it's not even an unknown. We see where this is heading. The level of overdose and substance use disorders becoming real now that brewed during the pandemic is enormous. It's going to be difficult to meet the need. So this upstream effort around children's behavioral health and transforming it for all California's young people, 0 to 25. So for your students, 0 to 25, yes, we said that correctly. It's not up to 18. It's not after you graduate high school only. It is at our institutes of higher education. And I have to say, USC, the UCs, other universities, you've pioneered and made incredible investments in how to serve the behavioral health needs of students. And I'm just here to cheerlead you on, help get it funded, and put it at scale. So all of your students, as well as the faculty concerned about the students, have a place to turn that's real and meaningful.
And I think thank you. And we appreciate that. And we have devoted enormous resources to that. And what we are seeing is that a lot of times it's just social support services that are very inexpensive to provide and that will prevent the exacerbation of things. And so it's got an element of prevention that's important to invest.
Oh, it absolutely. And I've said this for a long time as a card-carrying pediatrician who thinks a lot about adult health issues. I say pediatrics is the ultimate form in adult preventative medicine.
Yeah.
And in behavioral health, it's no more true.
Yeah. So I want to come back to something you made, a point you made early, and I think many of our listeners can recall how early on in the pandemic, at least, people were watching the data come and information about case counts. And we had such problems with reporting, but not only testing. And obviously it took a long time. And, there's a question of whether we actually got it right. We, our own Darius Lakdawala, an economist in the Schaeffer Center, has said, and this, you made the point that most of a large majority of the care in California is publicly delivered, but we don't know how well we do. We don't have the right metrics. No. Can you talk a little bit about how we improve those? What are the lessons from the pandemic? And then what does it mean for reporting more broadly in these in outcomes so that we can get more value from our public health system?
I'll start with one statement that is overarching, and then I'll get into pieces of the question. But as I reflect on this, and I've had the chance to work on a lot of, hey, how do you integrate this? How do you collect this? I think we as Californians need to expect transparency. And I think if you start to expect it and really hold people like me and agencies like the ones I run, and frankly, you as academicians and other entities to say, look, we want some transparency. We want to see how this is actually tracking. And I think the pandemic amplified that idea in a major way around data. And I think you put it accurately and interestingly. Not only did we not have the data, but I'm not sure that we had the right data. And let's just talk about COVID. Early on, case counts were everything. Cases were kind of our one shining light on what was happening. Today, I would say if I wake up in the morning and I want one number, I want to know what the hospital number is. So we also have to do a better job. So first, I think we didn't have the systems built to pressure test what we had for the pandemic. I mean, we broke systems. They were fine when you weren't reporting millions of negative tests
Right.
into the system. Like it could handle it. But the minute you started requiring negative tests so you can calculate a test positivity every morning before a governor goes out and shares with the state where we are, we broke it.
Yeah.
Should have we anticipated the need for it? I'm not sure. But we needed it. And now we have to move forward that we have better systems. They have to be more robustly built. We have to have code that can be fixed, not by somebody who retired 5 years ago. Like we need to have better systems.
Yeah.
And then they need to better integrate. I often talk about the integration of health and human services. And if I had the privilege to show a little slide about those integrations, I mean, the data is where it starts. We created something called the Office of Data Insights and Innovation for exactly this reason. I run 12 huge departments and 5 offices. We're 40-50% of all of state resources through health and human services. And we are just getting better at integrating the data. And it's hard to talk about social services without health services. And it's harder to talk about health services without some sense of what's happening on the social services side. I joke often that I wish I could flip my agency's name into the California Human Services and Health Agency, because human services often drive the health outcomes, not the other way around. So we need to do better on integration. And then, as I started, I think we need to be more transparent. And this isn't like overwhelm people with published data, but really spend time deciding what data matters, what data tells a complete story for whatever it is, whether it's behavioral health, pediatric, preventative care outcomes, or COVID. We need to choose the right information and then communicate clearly to the public why we did one thing today and we might have to do something tomorrow. Because I'm sure people will find it very odd when we actually transition to counting every single case to letting people know that the health of the hospitals is worrisome given the number of hospitalized patients. And that's the appropriate place to go, but it's going to take some transition communication and good data to share that news.
Yeah, and actually, I want to come back to the hospital question, but I will say on the data side, for wearing my researcher hat, California was early in releasing through OSHPD the hospital data, and we learned an enormous amount about length of stay and outcomes associated with hospitalizations, and actually, the revenue and the sources and how hospitals behave. And California was ready when the mergers and closures started happening to understand what it meant for hospital care delivery. And so it has enormous policy salience to do that. And as you said, we need to do that in all aspects of our health delivery system and social support system. So
one just to riff on this a minute more, one proposal that it's in the budget again, proposed budget for the 3rd straight year is the Office of Healthcare Affordability. And just to the point, this is a real opportunity to get a set of experts powered by the resources of the state to begin to really create some transparency on cost and affordability of healthcare, which is an issue for the whole nation, an issue for Californians. And when we think about the lasting concerns of Californians after you get over the immediate, acute, important worries around the pandemic, healthcare affordability sticks. Yeah. And so I'm proud of the governor for sticking with this proposal and saying the 3rd time may be the charm, and we could have even greater visibility into different layers of that data, because I'm proud of how we aggregate it and we can talk about it institution by institution, but it's not group by group or unit by unit, which is where some of those cost drivers occur. And I think being able to tell people the deeper story about what we pay for and what we get for it, I think is going to be critical to the transformation of where we go next with healthcare.
Well, we should get you to come and give a talk on that at the Schaeffer Center, because that's near and dear to our hearts. And I do want to talk about affordability, because for a long time, health economists had the view that, the most of the money was being spent in the hospital. Hospitals were inefficient. We closed a lot of hospitals, got rid of excess supply. And then the pandemic comes and suddenly we're worried, hey, we need more capacity in the hospital. And I'm pretty sure the correct policy response is not to build more hospitals. So what do we do about that? How do we prepare ourselves?
One of the key issues, I think, is in the process of closing hospitals, we didn't build up community-based primary care as much as we should have. And if you look at other nations, and I'm a primary care apologist, I'm a primary care pediatrician, I think preventative care, early care, accessible care in the community makes a difference for all of us. And I think we all experience that in real life when we have some healthcare needs. And if you look at the performance of different nations through the pandemic, many of the inequities, I don't know this for sure, but I have a pretty informed hunch that in a couple of years, when we look at what happened here in the US and what happened abroad in countries with more unified health systems, health access for the vast masses, a focus on upstream care, that we're going to find that that was a missing piece. And we often lament in behavioral health how we closed all the inpatient facilities but didn't build up community behavioral health. True fact. We're paying the price for that today, and Governor Newsom's trying to catch up a little bit now. This same mistake may happen on the physical health side, and I think that we probably need to push for ways to prioritize primary care, not just on the training of new physicians, as you and I talked about earlier, but also on the models that prioritize primary care, build different teams to deliver primary care. It's not just about the doctor, provider, nurse practitioner. It's about the people who work with them. Mm-hmm. And these community models really excite me on how we can transform that. And one day, I think, have the outpatient infrastructure to justify the level of inpatient infrastructure that we frankly are building towards, or collapsing towards, I should say.
Yeah, no, and I mean, we have a pharmacy school here. They are co-supporters of the Schaeffer Center, and our students were on the front lines giving out vaccines from the beginning. And you just saw, how important these alternative providers are. So, and they're obviously nurses and social workers and the like, and even EMT services and the like. But I do want to come back to this transformation of COVID. We're starting, you mentioned National Health Service, and I know in the United Kingdom, they've essentially stopped surveillance testing at this point. They don't test, it's become, maybe this is about the transformation from pandemic to endemic, but now unless you're symptomatic, they're not doing. So you talked earlier about how we needed to know the denominator. And the question is, do we still need to, we're talking at USC, we do surveillance testing, but
sure.
That's very expensive, and we'd love to put some of that money back into our educational mission. So I wonder, as we move from more broadly from pandemic to endemic status, which hopefully we'll be able to do in a couple of months, what do you see that meaning for surveillance testing, healthcare delivery, and the like?
So a couple of things. First, I'm grateful for the investment USC has made into surveillance. It's helped us all. It's informed our response. But I think expense aside, and I don't mean to dismiss it, in the classic question to a first-year resident on the wards when they say, "Oh, I want to order this test," the seasoned attending will say, "Well, what are you going to do with the results?" And the resident says, "I'm not sure." So we don't order the test. And the question now is, what are we doing with that information?
Yeah.
Like, is it really driving what you do differently? Maybe on a personal level, people should mask up, stay at home if they're positive. That's super helpful right now. But we are having to challenge some of the early assumptions because the level of visibility, our level of understanding, I mean, the way I kind of like to describe it is when we started, we were in a rickety old car with no seatbelts, bad windshield wipers, and bad headlights, driving down a windy road in thick fog that we've never been on before. Scary adventure, right? Now we're in a better car, better equipped, on a road that we're familiar with somewhat, mostly. Not that we're so familiar with it, but we kind of know what's happening. And the fog isn't as thick. So I do think we have to think about the same tools, but how we use them and deploy them differently. Now, look at flu. Every year, the way flu starts is it's a reportable case in October. People get excited in the clinical community when we start seeing the first couple of flu cases. And solidly in the middle of flu season, no one's testing for flu. People want to know like we start treatment when it could be effective without a positive test. And we year over year estimate the number of flu cases based on the number of people hospitalized with respiratory conditions. So, I'm not sure that we're quite there yet, but we are definitely taking steps to go into a model where we are treating it more like flu. Now, if I had the slides, and I don't want any of the listeners to think, oh, he's saying it's like flu, because it's not. It's not yet there. If I showed you an impact slide of COVID versus the last really bad flu line, it will blow your mind how it's 3 or 4 times, at least in every category, worse. So we aren't at a place where we can start saying, hey, it's just flu, let's manage it that way. But there are definitely approaches to influenza that will and should become part of how we think about COVID. I think it's going to have direct impact on testing. And the reason why I think testing will remain important, especially for vulnerable populations, is because in a scarcity of treatments, we want to target treatments to the people who are most likely to benefit and have their lives saved because of it. So there's an opportunity for California to really be on the cutting edge of how do we link targeted testing with immediate access to the treatments that save the most lives. And I think that is a thread that we are working actively on that is different than flu at the moment.
So I think that's it. You mentioned the COVID line is worse than the flu line. I'm wondering if the introduction of oral antivirals will actually move those lines completely coincident. And is that part of, I mean, at least the Pfizer product appears to be quite efficacious. So, is it possible that we'll get there faster as soon as there's wide availability of antivirals?
Well, I think, that is with every newly vaccinated person requiring a great deal of work. Notwithstanding, I think we will make ongoing progress with 12 to 17 and 5 to 11 vaccinations. I think we will see a whole number of the 0 to 5s get vaccinated probably towards the end of the month if it does get the approval we anticipate. So we're going to see some gains, but we're kicking and clawing to get every 0.1% increase in vaccination status of the case. So we turn to the important tool of treatments and therapeutics as the next appropriate frontier. And I think it's all going to be about how quickly we see those therapeutics made available. One, manufacturing, distribution, communication. And then the piece that I think will be important to evolve over time is the side effect profile of some of these medications. So, we still live with many people, and it's not necessarily the wrong way to think, but the benefit doesn't outweigh the risks. and some of the medications are going to have those risks, and people are going to take time. So it's going to take us a little time to get there, but I believe that we will see therapeutic advancements to really bring, as you put it, merge some of those trends that you see between flu and COVID at the moment.
Yeah, one of the things you see, we call it economic epidemiology. People respond to and say, so for instance, when we during lockdowns, a lot of people stayed home. A lot of the evidence is they would have stayed home anyway because we were all very scared of it wasn't that the government was saying, it was that people like me were scared to go out of the house. And similarly, when we see Omicron taking off, we see vaccination rates increase.
Right.
But I think one of the problems with therapeutics, and it's well known, is if people aren't going to get vaccinated if you rely on, if they believe there's an effective therapeutic. So it's a very difficult health communication message to navigate and then once you politicize that issue, I just have nothing but sympathy for you. That's the question.
Yeah, I will say that public health communication, as somebody who has a public health degree, and I think about my core curriculum back when I was a student, the students of the future, I believe, will have at least a quarter, maybe a semester of public health communications, because I think that we have learned the hard way that our ineffective communication approaches that have gotten a lot better. I think we all learned to be better communicators individually. I think we got better advice on how to frame things and move things forward, but it did cost us lives, and no better place. Granted, the environment to communicate in is a different one than it was before, but I do think that our work on communicating more effectively, attaching ourselves to authentic leaders and communities is going to be part of public health strategy moving forward in a more real way than it ever has been before.
Okay, so we're getting a lot of interesting questions coming through, and I've been trying to ask them in my own way. But I think one question that has come up is really, when will antivirals be widely available in California?
I can say that I don't think it's any sooner than the end of March. And that is a stretch. I think that we will start to see the increases in meaningful ways towards the end of March. Who knows when it's going to meet, supply will meet demand. I'm not sure.
So should we cancel the Super Bowl? Is that what you're saying?
No, I didn't say that.
And no parties on campus, though. We'll have to stay off. Another question is, building on your comment about needing to link social services data with healthcare data, a growing number of states are providing access to integrated healthcare, social service utilization data, and even employment data. So they're like, we want to know product when we measure value. Is this something you see that Office of Affordability might do, or something that would be at the statewide level?
So I think it could probably take many forms. The Office of Healthcare Affordability will be formed around a principle on transparency. The purpose of creating the data or developing the data and collecting it is to share it, because otherwise it isn't going to be used by the feet that matter, the voice that matters most, which are consumers that may make some decisions based on some of this information. And we also intend to use it to hold entities accountable for meeting cost targets. So in that way it will be. But I think there is a broader opportunity to really share more easily. It's interesting because I think there's a real intent and interest in sharing data. But then when the rubber meets the road, it's still hard to do. And a number of people complain about it, say, oh, it's hard. You got to submit this. There's 10 layers. So we need to do some work on improving the energy required to get to data that we already have, and then work together to make it more transparent or more available. So long way of saying, I hope that that's what we get to. Now, the question had some specific examples from other states. Would love to see what other states are doing. And, I said it throughout the pandemic. I believe it entirely. We want to be the state that learns the fastest. We believe we have some really good ideas and start a lot of really neat things, but we have a ton to learn. And if we can learn from one of our 49 partners across the nation, we would love to see it. So let me know if you can follow up. I'd love to see it.
We will do that and appreciate that opportunity. The other thing I'll say is, during the Trump administration, they had an executive order to release hospital pricing data and transparent. They got a lot of criticism because people said, what price? We don't even know what price is. And you're right, the data have started to be released and they're messy, but people are learning from them. There is transparency around it, and we're getting better at what we want to ask for and what they can supply. And, it's to the consumer's advantage.
Yeah, I believe so. I mean, we can't make the data better if we don't know why it's a problem. And that's, it starts with transparency.
And I know we're coming up close on time, but a few more questions. There's this issue of burnout and capacity. Is this an acute issue related to COVID, or is this just the healthcare industry is suffering from this?
Yeah, I mean, we talk about acute on chronic conditions. That's what this is. You've never seen a greater set of pressures than we have acutely on people who didn't expect to want to exit healthcare this soon, maybe would have otherwise been turned on to healthcare if it weren't for what they're seeing play out in communities. And it doesn't help that healthcare providers, of no fault of their own, went from heroes to villains in some communities. So I think it's real. When I think about the one thing that we need to advance and transform health and frankly social services in California, it's people. And not only are we not growing as fast as we need to, we're losing faster than we ever thought because of the pandemic. So I tell my team, stop cooking up new brilliant ideas. I will too, until we can have a workforce answer. And that isn't just train new people. I think it's new people for jobs we already know, creating new jobs, creating different ways to do the same jobs, and giving people the respect and relief that they need to come back every single day. I learned early on that this idea of workplace hygiene, I think we need sort of this concept of like hygiene in a profession. Like, how do we make it that we're hitting some basic kind of good expectations around the jobs that we provide in California, in healthcare in particular, so that people stay engaged. And I think this is going to be a problem. And I hope I'm wrong, but I worry we're all going to have to face it in our walk in healthcare in the next couple of years. Whether it's a delay in care or somebody you went to before that no longer provides that service, I think we'll all see it firsthand in the coming months.
Okay, and we're running out of time. So my last question to you is really about you personally and the investment you've made in public service. Our students are interested in public service, but often they end up at nonprofits or they may go into the private sector. Maybe you could share a little bit about how you ended up where you are and what motivated you.
Thanks for the question, and it's always great to get a little more personal. People say, "Well, why do you work in government?"
Yeah.
And I laugh at the question because I always have to take a step back and remind myself I work in government because I actually come to the work because I want to work for the populations that government serves. And if somebody else served them as broadly and effectively as government did, I'd probably go work for them. So I feel like I'm driven by an interest of working around population health issues and population issues which government has a very important role in supporting, and then safety net populations. So if you want to work for overlooked, overserved populations, government provided healthcare policy work, the things I feel privileged to get to do every single day, is really where so much of the activity is centered. And so I chose to work for the populations, and then I found myself landing in a government position. A lot of people will say to me, this isn't what you signed up for, the pandemic. And again, anchored in the answer I just gave, I often respond, I signed up to serve Californians. And this is what was required at this moment to fulfill the vision and mission of serving Californians. So sure, it's not what I thought, but I'm privileged to get to do it. So, my journey has been about the people and communities I deeply care about and finding the most effective and most impactful place to serve them. And that's how I ended up where I ended up. For what it's worth, that's kind of a summary of my quick summary of my journey. And what I think my advice to people is sort of forms out of that, which is figure out who you care about and who gets you up to work for, and go figure out who's doing that work most effectively. And if it's government, I'm excited for you to come join us. And if it's nonprofits, if it's the public, or if it's the private sector, good for you. It's just anchor it into who you think you want to work for. Because we're all working for some community or some effort. And I hope you feel connected to whatever that is.
Well, we thank you for your service, and it's an inspiring story. And also, I want to thank you. You have a very busy calendar, so we really appreciate your taking the time to speak with our community, and we look forward to working with you to move beyond this latest crisis. So, thank you very much, Dr. Ghaly.
Yeah, my pleasure, and thanks for the time.